morning, everybody. I wanted to give us a few extra minutes for those of you who trekked over to HSW 301. Did anybody take the food there? It's better food. Good morning. So welcome. So this, just to remind everybody of the format, so roughly every other month, the Grand Round Series organizes what's called the Clinical Case Conference. And the point of the Clinical Case Conference is to use a case to illustrate a particular clinical dilemma using the expertise of our faculty to help us work through those dilemmas. The case I'm going to present today, I'm actually going to present it a little bit different. I'm going to present it more as an as if it were my case, because what I wanted to do was actually demonstrate how I think this word formulation is probably a little bit inconsistently used, both in our department and in our training programs. And I wanted us to think through just a little bit about what would rigorous formulation be, and what would an ongoing hypothesis testing process be that we could all sort of focus on. I think we get a little bit caught in the jargon, but I'll talk more about what I mean by that. But whenever we're talking about formulation and whenever we're talking about a case conference, I think it's fair for the audience to question everything. And so what I mean by that is really, because I've thought a lot about this, you've probably been to a lot of case conferences that were underwhelming. Right? Let's be honest. And the question comes up, why were they underwhelming? What was it about it? Sometimes I think about it this way, because it relates also to thinking about any curriculum. If I'm going to get, dozens and dozens of well-trained folks who could be doing other things together in a room for an hour and a half, what value do I bring by discussing a case? What's the point in that context? Even I could discuss a case, I could get a curbside consult from anybody at any time. What's the value of the case conference? And so I thought what I wanted us to do is think a little bit about, as opposed to jumping to it, I think we jump too quickly with the word formulations. We jump to CBT formulation, or we jump to psychodynamic formulation, or we jump to biopsychosocial grids. Just thinking about what is actually a utilitarian definition of formulation that we could come back to. I'm going to weave that into, I think, I'm going to exemplify what I think are two problems with case conferences that tend to, in my experience, pop up when we're discussing cases. And hopefully, in the way that we discuss this case, we'll address how to think about those a little bit more rigorously. And then I also, one of my agendas also is just to sell the DBT program to you a little bit. And the reason for that is, independent of the theoretical model or the population that they see, they have a process of continually engaging and updating formulations of their patients. And I think that's something we could all learn from. We call it, it's a rigorous approach to formulation. I'm actually going to start a little bit strong, though, just to get us sort of in the emotional mood. And I just wanted us to start just by poking a little bit of fun at case conferences. I just want to pause for a second. Just think a little bit about a case conference you were at that you walked out of there and went, well, I learned nothing new, right, about that case or about psychiatry in general. Just think a little bit about what was that like? Why might that have been? And so I would say this is not a new problem. Right? This is not unique to 21st century psychiatry. In fact, I would encourage you all to read this article. So this was written, 45 years ago now. And I was struck by just how remarkably well it stands up. Just getting, regardless of the knowledge of the field, regardless of sort of the heuristics that we use, the way that we discuss cases is something that we really I think we need to put a lot of thought into. And so Paul Meehl, who Wikipedia says is one of the most 100 cited psychologists of the 20th century. Paul Meehl, he actually starts very strong in this. I really like this article. And so he says, well, I'm this faculty member at the University of Minnesota that's published a lot, and everybody thinks, I'm a distinguished professor, but I never go to case conferences, and they ask me why. Why don't I go? Come on. And his answer is actually pretty straightforward. It's that actually the intellectual level is so low that I find them boring and sometimes even offensive. Right? And he actually goes on to list, it's quite a long list. It's easy to get lost in it. He goes on to list, it's actually very rigorous. He's got like 10A, 10B, 10C, and problems that that he relates. I'm just going to illustrate two of them because I find, so what Esme and I did is we did a little bit of a pretend, and that was that she introduced me to this case, and I formulated it based upon how I think I would formulate any case that you gave to me if you said, Demian, I need you to do a formulation and present it to me. Right? So it gets the training in me mobilized. I go through the chart. I was in Apex for 20 minutes, that kind of stuff. I'm trying to figure it out. And I think a couple of things stand out for me. One, and that Dr. Mayo points out, is that we really, for whatever reason, when we formulate a case, I think it's because we want to be seen as caring about everything and being broad-based. And I think we actually stop using probability logic all of a sudden, and everything becomes equally important. And he points out that that's actually a real problem if your goal is to actually make a decision that benefits the patient. Your goal should not be to generate anything that could be relevant. Your goal is to actually prioritize things based upon what we know about the patient and the situation. And so we tend not to use probability logic, even though we often use it individually in clinical decisions. This patient is likely to respond to X because of Y. So for some reason, once I tell you to formulate, all you do is start listing a bunch of things that may be relevant. So he really goes after that one. I find myself doing that, so when we talk about the case, I'll give some examples. The other one, I think this relates to maybe why people find case conferences sometimes underwhelming, is that it's a little unclear what the task specification often is. And so I think this is getting at the why bring a bunch of people into a room to discuss a case. It should probably be either, if it's a small case conference on a unit or on a service, to come out of that with some decision that the group can help with, so decision-based. Or if we're talking about grand rounds format, probably some sort of practical decision teaching variant, right? I want to teach you why we made this decision, or I want to teach you how GBT would frame this problem. Not to listen to someone spinning out complicated ideas, right? I think that's and I think that's probably one of the risks of any case conference, is the kind of anything goes. And hopefully I won't engage in that. I might poke a little bit of fun at it, though. But I thought just for a couple of minutes, why don't we just find somebody, maybe if you could pair up in twos or threes. I was hoping everybody would be closer so that people would be closer together. And just really, just have a brief discussion, and just based upon your training or based upon what you think the word means, what's a working definition of formulation? We throw the word around all the time. We say you're supposed to formulate. We say give me your formulation. What do we actually mean by that? All right. So we've thought a little bit about this word formulation. So with that in mind, what I'm going to do is I wanted to introduce this case in the way that we often learn about a case. So we often learn about it. We get the sort of quick summary, that's sort of in the briefing room, or right before you're going to see the person, or tomorrow you're going to see X. And I want to make the point that whether or not you think so, you're always formulating. When you see how I define it, you're always generating hypotheses about information. And so the minute I give you a case, you're automatically forming hypotheses. Now, probably some of that will be implicit. You'll just make some assumptions and won't identify them as assumptions. But the point being is that if I'm just going to put up a few pieces of information, and you're already going to start generating hypotheses. So let's introduce you to Hannah. Hannah is a 21-year-old Latina. She's re-engaging in care, having previously been seen at Langley Porter for about a 6-month to a year period, when she was a minor. And now she's an adult, and she's re-engaging. If you look through her chart, these are the diagnoses that are relatively consistent. So if you look at the billing notes or the past history, she's received these diagnoses at least several times, and she was in the DBT program for several months. So Hannah's coming to us. Remember, she's coming back. And the story, the sort of quick story that you get when somebody's introducing the case to you, is that the reason she's coming back is that she actually left treatment rather suddenly when her mother was murdered. Her mother was murdered by her father. And after that time, she, for reasons probably related to the family and where she would live and the situation, she moved out of the Bay Area. It was in several long-term residential facilities, some of them quite far away. Most of them were actually brief. One of them, however, was a relatively long stay. So there was some chaos and brief stays, and then one particularly long stay. And now she's returning to the Bay Area, and you know that at least one of the correlates of her returning is that in the last treatment facility she was in, one of her dorm mates actually died. So we don't know the whole story. We just know that that's what happened. She's now living back in the Bay Area with her aunt. And we also know that she's been here a little while and has started engaging in care and was recently started on Wellbutrin, although there's a question of variable adherence. So let's just think a bit. So we've got this kind of a case. I bet you're already generating hypotheses about this person's mental state, about her vulnerabilities, and then really remember the practical decision-making question is, where are we going to start with her? Where are we already thinking we're going to start in terms of framing treatment goals, and what history do we want to flesh out? So I'm just going to remind us a little bit of these two problems, and I just want us to be aware that I think Hannah, for me, she was a great example, because I discussed this case a little bit with Esme. I was trying to do it as if I were learning it, so I discussed it with her when I knew just a little bit, and then I discussed it with her when I knew a little bit more. And when I knew just a little bit, I was particularly hooked by the murder, right? So in the sense that sort of dominated my hypothesis generation. It's just interesting. Not that it's not important, but I was struck by that. And so when I'm thinking about this, so Paul Malef, I have a critique of him as he's pretty wordy. So I thought I would summarize his recommendation is to make smart bets and curb your armchair philosopher, right? And I think this for me was a great example of a case where I found both of these things a little bit hard to do because the story is so compelling. What I wanted to do now is take a little bit of an interlude. We're going to dive back into the case with more information, and then we're going to ask Esme to give a perspective on working with a case like this over time. But I thought this might be a time for us to just maybe take a step back, and I'm going to have a little bit of fun. So I'm going to walk through my perspective on how I was taught formulation. So this will be the interlude, and I would say, and stay with me. I would say that what was interesting to me is when I asked myself that question, actually my thoughts became quite jumbled and jumped around. And what I was struck with is that it was actually impossible for me to think about formulation without thinking about the word psychodynamics or CBT or having something in front of it. Right? So it was interesting to me. That was just the way I had learned the word, is that I had never actually learned formulation separate from cognitive behavioral therapy formulation or psychodynamic formulation. And so I just thought it would be interesting. You know, psychodynamics is this one of those hard to define words. This is how Free Dictionary defines it. Cognitive behavioral therapy never really gets defined as a thing in the way that psychodynamics does. Always gets links to therapy, interestingly. So CBT is, there's always the T in CBT formulation. You don't do cognitive behavioral formulation without the T, apparently. But what I was struck by, my memories of being taught formulation is that, you know, it had this use of the word real that I've commented on before, which is that, are you really doing real formulation? Is it really real formulation? And in particular, is it really real formulation with a word inserted between really real and formulation, right? And that's kind of the way that I was taught it. And so I thought I would just, when I sort of free associated what came to me or how I learned it was that if you're doing really real CBT formulation, you have to draw a diagram, right? In particular, you have to put people's thoughts in quotes. So you're required to do that. You're required to draw some sort of circular diagram with causal arrows. And then if you're really fancy, you'll point out that the causal arrows might point both ways. Right, and so that was kind of doing CBT formulation. Again, nobody defined formulation separate from this. And then I also learned that you have to do homework if you're doing CBT formulation. And actually, to be a good therapist, your homework was to ensure that the patient did homework. Right? And so that was CBT formulation. So interesting, you could see conflates technique and formulation a little bit. If you ask me what was really real psychodynamic formulation, what I would say is, well, it wasn't so much diagrams, but psychodynamics had to draw triangles. And in particular, the practitioner had to be at one point of the triangle, always. That was important. It was also interesting that in psychodynamic, everybody went out of their way to say that diagnosis doesn't matter, but then they would spend a lot of time talking about the meaning of diagnosis, which I actually thought was kind of a mixed message. And if you looked it up, it was one of those where lots of people would write articles about what psychodynamic formulation was, and they would point this out very quickly. We don't care about diagnosis, but our primary use is to understand diagnosis. And then one interesting thing that I still struggle with is, for some reason, if you're going to be psychodynamic, you have to love the tautological use of the word psychodynamic. So what do I mean by that? What I mean by that is, you'll actually have people say being psychodynamic is being psychodynamic, right? So the careful reader here will see that one clinical use of psychodynamic formulation is apparently psychodynamic formulation, right? And so this is kind of the sort of mess that comes into my mind when I think about formulation, and I think it's related to the way that I learned it, was that nobody really took a step back and worked through a case with me outside of a theoretical frame. Maybe more modern, we might say let's do really real biological formulation. That sounds nice. I would say what that means in practice, in my experience, is that you put the prefix neuro in front of everything, and then you also use the word diathesis. Which actually I had to look up. If I'm honest, I wasn't exactly sure what it meant, but I was pretty close. So this is what a diathesis actually is. So this is maybe what ends up for us. Oh, and interestingly, Paul Mail is the co-founder of the stress diathesis model. So just to bring it full circle. So I think what ends up happening then is you end up using this word biopsychosocial, and if you look at a lot of the national guidelines, or you look at sort of what people will say, they'll use this, and it's kind of, I think it's kind of the art of the possible, right? So this is kind of the agreed upon place where everybody can put stuff. If I'm going to be critical of it, I might say something like my 9-year-old son would say to me, which would be, "Thanks, genius." Right? But this is the kind of thing I think that everybody agrees on, right? Would be something. I'm not saying this isn't useful. I'm just trying to point out how I learned the word formulation and how I think it ends up getting used in practice. And so just to poke a little bit of fun, I would say, if I'm going to fill this out, I might fill something like that. And one thing I want to come back to, because I think this is what often ends up in practice, those terms that we never really got away from, meaning formulation that can't be used without CBT, or formulation that can't be used without psychodynamics. Where they sneak in is that biopsychosocial lets you put kind of anything in the psychological part and still be called biopsychosocial. So it actually doesn't separate cleanly a sort of separate definition of biopsychosocial formulation. So, and pedantic interlude, right? So let's talk a little bit now about maybe a way to think about formulation that I want to just sort of simply define it in a way that I think, and I vetted this with Marty, and he agreed with me. So we've established a standard of care. But just because I think these are words that people throw around, and I just want to make sure we're using them in the same way. So you often hear this. This is sort of true. Although I'm not sure you could say formulation is the summary of unique traits. What you might say, it's a summary of working hypotheses. That will, of course, involve unique traits, but it will also include shared traits. So it's not like you can say formulation is separate from diagnosis. And so I would say diagnosis you might even think of as one of the first steps in formulation, and it's probably one way of organizing epidemiologic data. And remember, Paul Mail reminded us, if you're going to make a smart bet, we have 50 years of epidemiologic data to help us make a smart bet, so we shouldn't ignore those bets, right? I define formulation very simply. This is not my only definition. This is based upon the root word and sort of, in a sense, the sort of more working definition that might even exist outside of psychiatry. So I would just say all you're doing is you're summarizing and synthesizing salient facts. So it sounds simple, but let's think about it a little bit more, right? that we're summarizing and synthesizing salient facts. Salient, I think, is one of the operative words here that we'll come back to. And you therefore generate a series of explanatory hypotheses about cause and effect. Right? So the value of formulation is that it summarizes and prioritizes and develops hypotheses that are testable. And if you want to throw some math in, I'm not going to force you to go through Bayes' theorem, but if you wanted to throw some math in, this is what it should hopefully help you do. It should hopefully help you base some probabilities based upon the information and the evidence that you have and the prior probabilities that you have. So let's come back to the case. And I want us to, we're going to walk through, we're going to flesh it out now. I wanted to flesh, the part two fleshing out is kind of the, now I got to know this person a little bit, and so I've seen them a couple of times. So I've done an assessment. So I fleshed out some of the history, and I've started to think about a treatment plan moving forward. So just to remind us, this is Hannah. This is the information that I had sort of pre-assessment. And then when I get to know her a little bit, I realized that you know, her chief complaint is that she basically wants to come back into the adult world. She does feel like that long stay that we mentioned reduced some of the problems she had with self-harm and restrictive eating. Those seem to be improving. She fleshes out a little bit more of the social history. Her mother was a single mom by choice. That she, until she left the Bay Area, she had been in a lot of private schools. And that drug use has not been a problem for her, although she does use alcohol occasionally. We don't get anything from family history that stands out. And when we ask her what her goals are pretty straightforward. They are, she wants to transition and start an adult life in the Bay Area. She wants to get back into schooling. Right? She had a very disruptive schooling. And she wants to find some new and stable friends. She wants to decrease, and this is related to what diagnostically gets put under PTSD, she wants to decrease some of the anger she has at her extended family, while at the same time increasing contact with her extended family. I'm going to guess that the anger is part of what gets in the way of increasing the contact. And she does want to have fewer intrusive negative emotional memories. She also wants to increase goal-directed activity in general, increase positive activities, and reduce her residual depressive symptoms. So during her assessment period, and we'll sort of stop here, but an interesting thing happens is that she travels to bury her mother's ashes with her extended family. I'm not sure why this process was delayed at this point. And several days later, she presents to the emergency room with the first episode of cutting that has been, at least since, to our knowledge, the first time in a while. So let's just maybe think a little bit with your partner again. Just think a little bit about, based on what we know now, where would we start in generating hypotheses? And now that I've given you a fair amount of facts, how would we summarize and prioritize these facts? Talk amongst yourselves. All right, let's come back to the large group. I want to make sure that we keep things moving so that we get out on time. So, you know, like any formulation where you just get to know somebody, we're generating hypotheses. And so the question really is, how do we organize the data we have, and what's a sort of theory-driven or scientific approach to sort of moving forward with that data and generating new hypotheses. This is kind of what, so I felt like if I was a good student and somebody was going to sort of grade me on this or give me feedback on this, I would feel obliged to fill this all out. And so this is what I filled out. So I'll just leave it up for a sec. This would be my biopsychosocial formulation based upon my initial assessment. And so I think, you know, just to remind us, these psychological ones are the ones that I think are the most theory-driven. Right? So the social history and the biological sometimes seem to be stating things that we all know to be true anyway. You could say reactive amygdala is kind of saying affect dysregulation in another way, right? And the social information tends to be more factual. But these are some of my, I would call these assumptions. These are assumptions that I'm making or hypotheses that I'm making about this person's mental functioning that relate to my understanding of attachment. I wanted to use the word introjection, which is the unconscious learning of internalized schemas and beliefs by being around somebody else. That was quite disruptive. And definitely the current attachment figures for extended family, there seems to be a lot of ambivalence. And of course we can't ignore the fact that she has this episode of cutting soon after the burial of her mother. So I think my treatment plan, probably, if I'm honest, would have been refer to DBT. Just being honest here. I probably would, if I were one of the providers, I probably would say, you know, we have this nice short-term grief model. This seems like an appropriate case for this. We could identify a complicated grief reaction, maybe an extended one. And then I might have probably thought this might be the place where if we flipped into what we call open-ended therapy, I might want to talk about a long history of disrupted attachment over time and how that has affected her schemas and her object relations. So that would be sort of what I would do with it. And so I thought what I would do now is introduce Dr. Esme Schaller, who's a psychologist who who's the director of the DBT program. And so what I asked her to do is, because actually the DBT program has some knowledge of working with cases like these, what would be the sort of rigorous approach that they would take as a program towards formulating this case? So let me just welcome Esme. And come on.
Thank you very much, Demian. That was a lot of fun already, so hopefully I can live up to that. I actually want to go back to Demian's slide for just a second, because I think if you think about that idea of formulation as summarizing and synthesizing salient facts, it's really hard to do that with real people. We're really complicated, right? And there's a lot of different things going on. You saw the list of diagnoses and list of different problems that this case has. And so that's how you end up here and how you end up with a few different possible pathways. And so ideally, I view formulation as actually telling you, the clinician, what to do, and not necessarily who to refer to, but actually what tasks. So we're going to drill down today, hopefully, to then what will my next 5 to 10 sessions look like, and how will I continue to revise that formulation. So my main point today is that we want you guys to be scientific, that science doesn't stay kind of if you're doing your MD, PhD, and you have your science over here, and then you have your clinical work over here, but we actually try to marry them. It's called the Boulder Model in psychology. We're a little obsessed with it, and I'm trying to bring it to psychiatry as well. So that's our goal. So when you think of just scientists in general, what do you think of? Here are some things that I think of, right? So I think ideally scientists are precise, they're curious, they have to be tenacious. Research takes a really long time. It can be a little boring at times. You have to stick there. And ideally, what you're doing is supported by previous work that's gone before you. You're not just making stuff up, right? And you're open to being wrong. Okay, does everybody agree that these are characteristics of scientists? Okay, so you can be really scientific. I don't know why I chose Batman today, but I like the idea of him and Robin doing science. So I started there, and you'll see he shows up a few more times. Ideally, scientists are not wedded to their ideas or overly confident, or think that we know better than the data, or get pulled into little rabbit holes when things are exciting and things are interesting. Of course, we all do this. Okay, because patients are really interesting, and patients pull us away from the data, and patients get us like, oh, but that, like the murder, right? And we get really excited about particular things, and we get pulled to different places that may not make sense with our data, that may not match with what the information that we're actually getting. And so my goal today is to help you be more like this first scientist and a little bit like this second scientist. And I want to say with the overly confident thing that this really applies to all of us, because the more patients you see and people that have been seeing patients longer, the more they start looking alike, right? I've been doing DBT for 12 years, and if I meet someone one time, I've got a treatment plan. I'm usually wrong. Even though they look a lot like many of my other DBT patients, if I don't pay enough attention to the data, I'm going to take them a wrong direction. So this is not a criticism, more broadly, I think that we're all prone to, and it's something that we have to be aware of. Okay, so our idea is that we're going to be using case formulation as a map, but it's kind of a magical map. It's sort of like the Marauders map in Harry Potter. Sorry, I'm in the middle of it right now again. But we have to keep revising it. We have to keep adding new things. We have to keep changing it as we learn more and as we get more data from our patients, right? But that's what we're thinking about today. So as Demian was saying, you can formulate from any theory. We're trying to give you this broad idea of formulation, right? And we're using the theory as a guidepost, but we may integrate things from different theories or take different steps along the way depending on what data comes from our patient, what shows up. So we're going to keep generating and testing hypotheses. You heard Demian say this multiple times. This is going to be the core of my point today. So today we're going to use DBT formulation as a guidepost. And part of that is because, for me, it helps me synthesize all those different complicated things and prioritize effectively. But we really didn't want, even though Demian had his hidden agenda of selling us, we didn't really want this to be about DBT specifically. It happens to be what works for this patient. But I think the same sort of guidelines and ideas about testing hypotheses and revising and come back apply across formulations. So ideally, my formulation is going to answer a bunch of questions for me that then help me move forward with how I'm going to help this client reach her goals. My first one is, what are her goals? And this one is one that we can often skip, especially with really complicated clients or where there's a lot of acuity, because our goal is clearly keep this patient alive, right? And I need to know what I'm keeping her alive for. And so we'll be coming back to that idea a lot. And Demian showed you a lot of goals, and I'll talk about which ones I prioritize. I also want to know what my theory is. So how do I believe I'm going to help her reach those goals? And we'll talk about that a little bit. Based on my theory, how do I generate and test hypotheses? So you may do it in different ways in different theoretical orientations. I'll talk about how we do it in DBT today. But again, I think you're still going to do that. And then when I get this data, how do I prioritize it? Because you're getting a flood of data, as you saw, and we didn't tell you half about this case. There's a lot of data. So how do you prioritize? How do you decide where to go? And then based on both the data and my priorities, what is my pathway to meet those goals? So what do I actually do? I don't want this formulation to just be an interesting intellectual exercise. I want it to actually tell me, okay, and now that I know this, I'm going to do this. Does that make sense? Okay, so a refresher on Hannah's goals. Again, she gets to decide what direction we go on the map. I cannot stress this enough. It is pointless if I'm directing, if I'm driving the bus, okay? And I'm only concerned with the symptoms goals. If you guys remember that second page that Demian put of what she wants to do about some of her remaining PTSD symptoms and her remaining depression symptoms, I'm only concerned about those in so much as they interfere with her life goals. So I'm always pushing my patients to be talking about what are they moving toward as opposed to what they're moving away from. So we see kids in our program who've made 27 suicide attempts, been in and out of the hospital multiple times, and I want to be less depressed is not a good enough goal for me, because then I don't know what I'm replacing it with. Like, why bother? Why do you want to be less depressed? What is that life that you're going to try to live instead going to look like? And so that's something that I spend a lot of time on early in treatment. So here are Hannah's life goals again. She wants to start an adult life here in the Bay Area. She wants to continue with her schooling, go to community college, find some new and stable friends. She has friends kind of scattered around the country from treatment programs and would like to have a present social life. Okay? I'm going to look at this through 5 different theoretical lenses. We're not going to go through all 5 today because we don't have time. Thank you to Barbara Stewart for this beautiful DBT formulation formula picture. I'm not good at these on PowerPoint. But these are the different ways that we think about the data that we get in DBT. So I'm going to spend a little bit of time on biosocial theory, a little bit of time on stage theory, and then I'm not going to lie, I'm always going to spend time on behaviorism because that's who I am. So we'll probably stay more over there. Dialectics are going on in the background. They're just a little bit beyond the scope of today. So there's a biosocial theory in borderline personality disorder. Many of you have probably heard me say a little bit about. I'm going to do a 2-minute version for time because we have a lot to discuss. It's basically the idea, and this really kind of is the diathesis stress model as Demian was talking about, the idea that about 10% of the population is born more sensitive than the average person. They are quickly reactive. They're highly sensitive to smaller stimuli than other people, and it takes them a long time to come back down. They have something called slow return to baseline. This, in and of itself, is not a problem. My team will readily assent that I cry like 4 times a week. You can be a successful human and have a high vulnerability to emotion. What happens is that it interacts with something we call an invalidating environment. So something in your environment that communicates that your emotions are wrong, don't matter, don't make sense, are not as important as other things. So on the extreme end and kind of the classical formulation of borderline personality disorder, you think of kind of extreme physical and sexual abuse as a child, but it goes all the way up to I had a young woman a few years ago who was a very kind of sensitive, melodramatic artist. I say those terms with love. And both her parents were Silicon Valley engineers. And they were like, what is going on? Right? Why are you so dramatic? Why are you so upset? Calm down. And this repeated over her lifetime. She looked the same as someone who's had kind of chronic abuse because it was so invalidating and she had such a huge biological piece. And we're assuming that these interact over time. So the more invalidated you get, it affects your biology. Your emotions get bigger because our emotions are made to communicate with other people. And when our emotions get bigger, you're harder to validate because you kind of are being dramatic, so people don't get it, right? And so then over time, this makes things worse. That leads to a host of behavior problems. Notice there's no psycho in the biopsychosocial theory. It's just the biosocial theory. And I think, in terms of DBT, Marshall Linehan did this on purpose so that we make fewer assumptions. That's our goal. But it does help us develop hypotheses when I test them. And it helps highlight the importance of symptoms. So with borderline personality disorder, as an example, I don't think anybody would say that, like, chronic feelings of emptiness is the same import or the same kind of strength as a symptom as chronic emotional dysregulation, right? The chronic emotional dysregulation and the suicide attempts are what really get in her way. Chronic feelings of emptiness aren't great, and I do want to work on those, but I'm not going to prioritize them. They're not the first and kind of foremost thing in my mind when thinking about meeting her other goals. So then I can test hypotheses as they're related to the theory. So how does the biosocial theory relate to Hannah? It turns out, before this murder, before anything else, she was always a really sensitive kid. Her mom was kind of pull herself up by her bootstraps. I'm going to succeed in a white world no matter what happens. I'm going to be super, super tough. And Hannah was always pretty sensitive and did not feel like her mom got it. And then she was always the only kid who was low income in a lot of different settings because her mom was a tireless advocate, but she felt like she didn't fit in any place, right? Which leads to some of her earlier forms of invalidation. Right? So Mom says, yeah, she was really sensitive from the very beginning. None of us knew what to do with her. None of her cousins are like that. None of my sisters are like that. Everyone was sort of confused. And I know this because I worked with Mom prior to the murder back when she was in the program for the first time. The other big form of invalidation was she knew of her biological father, and Mom consistently denied that he was her father. So she sort of consistently questions herself and felt like she was going a little crazy. So this helps me understand motivations for some of Hannah's actions, but I'm also not going to assume that I know this about any given behavior, right? I'm not going to say, oh, you did that because X, Y, and Z. I'm going to be going in and testing those hypotheses, and I'll talk a little bit more about that. In general, though, I want to give you the umbrella that I'm assuming that one of four things causes problems. I'm using problems very broadly, right? So it causes things that get in the way of Hannah meeting her goals. And this comes from Kelly Kerner, who's another great DBT trainer. One is skills deficits, right? That's an obvious one. The patient doesn't know what to do, how to act in a particular situation. Another is that the circumstances reinforce dysfunction or fail to reinforce functional behavior. So she's trying to emit an effective behavior. She's trying to reach out to a friend, and the friend doesn't call her back. Or she's trying to express emotion to her aunt, and her aunt is confused or tells her that that's not the right thing to feel. Right? So those attempts at acting the way that she wants to be in the world are punished or ignored. Another is that she's got emotional responses that have been conditioned, that have been reinforced over time, that get in the way of her doing something skillful. So she has the behavior, and if she's not emotional, she can do it just fine, but she's having all these emotional responses and then can't do what she needs to do. And the last is that she's got faulty beliefs or assumptions that interfere with effective behavior. To be honest, I lean away from the cognitive, so I don't spend a lot of time on that one, but sometimes that gets in the way. That's my personal thing. So I think that, I have these ideas here of how she got this way, and I have these ideas of what might be getting in her way, but I still don't know where to start necessarily, right? So how do I test these hypotheses? What are we going to do? How are we going to figure it out? Anybody know? Anybody have a guess? I'm going to do behavior chains. It's the best. Okay, so I'm going to figure out, like with this particular example of going and spreading her mom's ashes, which was delayed because they were going back to their home country and they had to wait until a bunch of different people in the family could do that. I'm going to pick apart moment by moment what happened that weekend. And I'm going to say, well, we have some ideas about what made you vulnerable. What is the problem behavior is the cutting, So I would put that. And then I'm going to see what were her thoughts, what were her feelings, what's going on in her physical body, what was she noticing, what are the things that her family members said to her, and figure out were the precise things that got in the way that led to this experience of cutting. So I don't have to just kind of make my whole theory whole cloth. I can be curious, and I could say, okay, let's pick this apart. Let's see how you got there. The other thing that we do in DBT, and this is related to stage theory, is we have a way of prioritizing. So many of you have seen this before as well. The top of our hierarchy is always life-threatening behavior. So if there's suicidality, if there's self-harm, which increases your risk of suicidality, we're going to address those things first. Then we're going to spend a lot of time on therapy-interfering behavior, like not doing homework. Demian wasn't wrong. Homework must be done at all costs. That's a true stereotype. But also not attending session consistently, being emotionally avoidant in session, even if she's not intending to. I'm assuming most of the time she's not intending to, but it's still getting in the way. So we're going to address that. And then the last thing we're going to do is address quality of life. Right? And for her, what we're doing right now is a lot of quality of life interfering behavior, making sure that we can get her the friends, make sure she's in school, doing those kinds of things. And to target these three categories, I'm going to assume that she needs skills. But again, I don't know if it's that she has the skills and can't use them, that she doesn't know what the skills are to begin with. I'm going to figure all of that out as I go. So just to give you an idea, this is our particular hierarchy for Hannah. So again, suicide and self-harm are at the top, in that top category. Food restriction, and emotional avoidance are in the middle category. Food restriction, she's not physiologically underweight. She's not in danger with her eating disorder. But when she comes to session, she hasn't eaten all day. We don't have a good session. Turns out you can't do a lot of good work with someone that has no glucose in their brain, right? So she needs to eat a meal before she comes to see me. So we have to address that so we can actually get toward her other goals, right? And Demian mentioned that she doesn't have any history of drug use, but she's found out recently marijuana really helps you avoid emotions, turns out. So that's now on our quality of life list of things that we're working on, as well as missing school and isolating herself to behaviors that are really against her long-term goals, right, of engaging in school and making friends. Just to give you an idea of how it's prioritized. But again, what do I do with that information, right? Because some ways you can say, well, this is just, I've synthesized everything. It's a triangle, psychodynamics loves triangles, but it's also a chart like the biopsychosocial, and now I just have another list, right? So I need to actually do something with this information to make it useful, to make sure that I'm helping her meet her goals. So the theory helps me organize, and then I test hypotheses and go along so that I can then develop a list of therapeutic tasks that the client and I agree on that we're prioritizing. How do we make that task list? We have to do more behavior chains. We're coming back to this process again and again to refine our hypotheses and make sure that we're in the right place and that we're making those decisions that will help her move forward. So Demian sort of hinted at this, but I want to highlight that case conceptualization is never done. You don't fix it and have it finished. And it seems like an obvious thing, but I think sometimes when we put a lot of time into it, it can be like, it's done, there's my conceptualization, right? And I have it finished. But clients keep living their lives and doing new things, so we have to come back to it again and again and again. And as Demian mentioned, we have a formalized process for this on our team where we present our conceptualizations every couple weeks and make sure that we're not missing anything and have a particular question that we're asking. So ideally, my formulation, again, is answering all of these questions, but I'm getting back to this last one, is based on the data and my priorities being global for mine and Hannah's priorities. What is my pathway to meet these goals? So here I've got my task list for Hannah that we have been working on that she knows. So one is to build motivation and commitment. So it's been hard for her, given how much she's flip-flopped from different treatment programs, to stick with something. And that's a case where that fourth category of cognition's getting in the way has come up quite a bit for us. So we've been thinking about ways that we can enhance that using motivational interviewing strategies, using little commitment strategies like her making a verbal commitment or making a written commitment to do things. Turns out that increases the probability that your clients will actually do things. We're also helping her aunt reinforce effective behavior. So her aunt has her own kids are out of the house, and she very much is like, well, she's 21, she can just do things. And she's 21 but has lived in treatment facilities for a really long time now, and so she turns out she doesn't know how to do a lot of things. So making sure that aunt is present not only when she's suicidal, and in fact maybe a little bit less present then, but present when she's doing effective things, when she's reaching out for friends, and when she is going to school and paying a lot of attention to those things. We all respond to reinforcement. People have heard me say this many times. You would not be here right now if someone wasn't concerned that you were here, you weren't getting CEs. I really love DBT, but if UCSF stopped paying me, I have to eat, right? So we all respond to reinforcement, and it's important to make sure that it's happening enough in the environment to support the behavior that she wants. And she needs to reinforce the environment more. So because Hannah has had all these experiences, she often has a very flat face, and people think that she doesn't want them around, including her aunt and sometimes me. So we worked a lot in session of like, okay, so when you write down on your card that you feel a 5 out of 5 connected to me, but I look at your face, it looks like a 1 out of 5. What can you do right now to show me that you're invested in this relationship? And then how can we practice that with your aunt? How can we practice that with new friends that you're making so that they will call you back and they will want to spend time with you? Related to increasing reinforcers in school and her social circle. We do want to shape her therapy homework completion through positive reinforcement. Mentioned how important that is. She's doing a lot of behavioral activation to target her depression, right? So she wants to get out and do things. She wants to be in school. She wants to be making friends. We're increasing validation and self-validation, which is a very DBT target. And increasing mindfulness to emotions. So she's dialed herself down because her emotions have been so problematic in the past that most of the time she's numb, and then kind of blows up later on. The very typical kind of more functioning pattern. If you have had borderline personality disorder and you've been all over the place in the past, just kind of trying to turn the emotions off can let you be a little bit more successful, but then it pops up at inconvenient times. So we're working on helping her experience the emotions as she's having them. This means that we're not doing a lot of other things. And as Demian was mentioning, it's not because they're not important. It's not because we don't think that they're essential. It's just because they're not going to help her meet her goals right now. And if she's not in school and making friends and kind of building a life here, and all we're doing is kind of focusing on grieving her mother, which she did a lot in all of those residential programs, we're not going to help her move forward, and the other goals are probably going to fall to the wayside as well. And so again, this is collaborative. This has come up with her, and this has come up with me based on my theory. But it's been clear, that a lot of people around her have the hypothesis that that is what's required, and that if she just sits down and spends enough time on the grief, all of this other stuff will go along and be better. Meanwhile, she has clear skills deficits and clear things that are getting in the way of her meeting these goals even on her best days. And so she has agreed that that's not the most effective thing for her right now, and so that's not where we are. I imagine we'll get there eventually, but it's not what makes sense at present. So, assessing patient goals, sticking to a structure, a theory to test the structure, and sticking to the data and prioritizing. Those are our big things that we're going to do. And then revising over and over and over again. So I can't stress enough that this is not a static thing. And then that helps us remain patient-centered and destigmatizing. So if we're taking her seriously and we're believing that she has goals that are important to her and that she would like to work on, then I am meeting her where she is. I'm accepting that this is what's important to her, and I'm not thinking that I know better, that this is the real root of something. I'm assuming that we can get to what she needs to get to based on testing these hypotheses through our behavior chains. Make sense? So my last reminder is that all behavior serves a function, and nobody does anything out of the blue, and this is why hypothesis testing is so important. And I think, Demian, you have some final questions here for everybody? Or are they not supposed to be there?
No, probably for questions. We can just leave this up.
Okay.
I wanted to hold myself accountable, and so you don't have to answer these, especially if the answer is no. But I wanted it to be clear that when we talk about formulation, this was how I wanted to frame it, and this is why I really wanted Esme to introduce this case, because I personally think that without well, let me put it this way. So the way I learned formulation was theory forward. What Esme is presenting to us is theory as a way to guide certain aspects of formulation, but the collaborative patient relationship and the hypothesis testing takes center stage, not the psychological theories. And so I think that to me is a very important step that I find I don't actually do most of the time. I actually am implicitly theory forward. And so my goal was really to think about, does talking about the patient in that way help us make a decision about the patient? Even, again, in this case, in a didactic format. Obviously, we're not here to make a decision about this patient as a group, but in a smaller case conference, that would hopefully be the goal. Yeah. But we could just stop generally for questions. We have plenty of time, folks. Yeah. Well, thank you.
Oh, come on. Yeah.
Dr. Foose.
That was a really great introduction, I think, for all of us to the PBT formulation. What I was hoping you guys might grapple with, and briefly, is the idea that when we engage in a modality-specific formulation, we've already formulated the patient to the extent that we pick that modality. So what do we call that formulation? The one that happens before we pick a modality. Is it just that a patient happens to walk into a CBT therapy process, so they get a CBT formulation? Or is there some process by which we're understanding the patient that happens first, where we say, based on my formulation, CBT is an appropriate fit for this patient, or DBT? And I want to talk a little bit about the pre-formulation formulation, or the really real universal formulation.
I like it.
The common variables, maybe.
Yeah. I mean, actually, just to bring, your first point I think is very important, and that is that, in a sense, our system of care, we don't think about it this way, but it pre-formulates both sports. Right? So I mean, what I'm struck by in, say, IPT for grief is that the clinician who's going to provide IPT for grief wasn't involved in formulating whether IPT for grief. In fact, it may actually be a little bit, it may have been a little bit, maybe even a little bit random about, like, somebody needed an IPT case and this patient did have a loss, ergo, right? You know, ergo. And so I think that's a problem with the system. The way I often think about, so this is my observer view of, say, DBT. One of the, and this relates to, do I have this slide again? Yeah, this relates to Paul Mail's sort of first point here, right, which is, you know, make smart bets. I think, you know, this is the value of epidemiologic research. This is the value of a field that builds over time. Is that the diagnosis of borderline personality disorder, if made accurately, actually probably aids in the formulation more than any of those individual details that kind of were the shiny things that grabbed my attention initially. And so I often have a problem when I think what we often poo-poo diagnosis as not being real formulation. But I would say in this case, the smartest bet for Hannah was to approach her from a DBT theoretical frame based upon the prediction hypotheses we could make from the diagnosis alone. And so that's sort of, I would make that argument there. Am I answering your question, or am I just rambling? A little bit of both. Mm-hmm.
I think we do want to think about, you know, are there initial ideas for maybe it is diagnostic, maybe that's
Yeah, I'll add to that. I think that's definitely true, and that's our, you know, I think are diagnosis or other things that aren't specifically diagnoses, right? So like if someone's had 8 hospitalizations, I'm going to say, yeah, send him to us, and then we'll go from there. But I think there's still a pre-formulation that you're doing, that you're doing an assessment in that particular modality with that person, and you're making your kind of initial skeleton formulation if you're seeing if it will make sense. So I can only speak for our DBT and CBT programs in the Young Adult Family Center, but we get referrals and we'll do an assessment and make that initial formulation, and if it doesn't make sense, we'll say this doesn't make sense. This isn't a good fit for CBT or DBT because it's not, your goals are not these kinds of goals. We'll often have, at least on the DBT, usually they want DBT. On the CBT side, we'll have people that are like, well, I just want to talk. And we're like, oh, yeah, I'm not that kind of therapist. Like, where you can't just talk. And I think that, but I think you're right. It's that, we're not, the intellectual, practically speaking, most of us are doing a type of therapy, right? Most of us are doing something. And so the intellectual exercise of having sort of a universal, non-labeled formulation and then choosing a treatment pathway from there doesn't happen very often. I think partly is an artifact of the system, and partly because sometimes it doesn't make sense, because if we do know a diagnosis, we know what the evidence-based treatment for that, or at least what a couple different evidence-based treatments for that should be, and then we're often choosing from there. Barbara, did you have an additional?
Yeah, I think getting at that, what are the critical elements that drive a case formulation, regardless if you're doing DBT, CBT, or psychodynamically informed? And I'm sorry, I missed, new stuff in the rain. I'm really here to see all the stuff that you add here. But, it might be worth talking about those common elements, right? So it's not necessarily a diagnosis, but what's the chief complaint that's driving the dysfunction, right? And so anyone, regardless of their orientation, can probably come with some training, come to a consensus about what that is, right? And then also, in the team, the team perspective, right? So what drives the dysfunction and what drives the distress, which is really the core element of diagnosis, right? So if you're not diagnosis driven, you can still be driven by what the complaint is and what's causing the most, distress and dysfunction. And then from there, that's your starting point. Right? So I think that's where, you don't have to be a DBT therapist to come up with something as, driven and structured as a case solution.
Another plug for evidence-based assessment from Dr. Barbara Stewart. Yeah. Other questions? Yeah, Martin.
You're probably thinking I'm going to say something critical, but I'm going to say something supportive.
Thanks.
Marty. I'll say the rest later.
Okay.
Having the crisp theoretical sequence, like in debate or chain analysis, allows one to have in case competence a leader who's going to stick to one topic at a time, so that the multiple people trying to say something will talk about one thing. And that's what we need in our case conferences. Strong leaders that can hold the discussions to interactive topics, but one at a time, interactions at a time. That's the real advantage. So when you have a group doing a case conference or one of your DBT cases, like Hannah, you're all talking about the same thing at the same time. You say, well, let's go down here, and now let's discuss this. And that's what's the interaction of this with that. And I think we should strive for that kind of thing in all case conferences. We should be long enough to get information from the different faculty and trainees.
Yeah, I absolutely think so. And I think, did you ever hear Marty's comment? Sort of. Yes? Okay, good. Yeah, and I think that's another thing that Neil's talking about in terms of even if we don't have that kind of crisp structure, if you're doing a different kind of insight-oriented therapy or something else, knowing what your question is going into case conference and knowing what the purpose of the case conference is, I think is essential, right? And that can help, then that strong leadership can still help of like, wait, no, we're trying to answer this question, as opposed to like, well, I'm really fascinated by this, which I think is very tempting. People are interesting. None of us would be here if people weren't interesting, right? Yeah, Ning.
So, in this case with the diagnosis, I can see how you would go to structuring and that formulation, but in a case where the diagnosis is depression and there's not a clear way to, have treatment, how do you, I was talking about the psychological part, you said
Yeah, so first I would just say I would point you toward the psychotherapy integration literature. Marv Goldfried is a big leader in that and looking at like what are the common elements among different theoretical orientations and how to prioritize among different things that are still evidence-based. But like you said, with depression, there's this wide open field, right, where you can go a lot of different places. I mean, if I answer that question honestly, I don't. I'm a behaviorist. It works for me, and I think it's the least stigmatizing thing, and I see it work for people consistently, and so that's what I do. And if I think someone's not appropriate for that, I'll let them know. But I also like only do DBT at this point in my career. I don't know if you have other thoughts on kind of choosing from the menu, because I think it's a big question in training, and it's a hard thing to do.
Well, I just want to separate two issues. So one is that because borderline personality disorder as a research diagnosis is associated with a treatment that targets particular aspects of it, that this case just happens to be one where the diagnosis provides valuable information, right? So I think when Paul Meehl is saying make smart bets, what he's saying, you know, there are some DSM diagnoses where you have a ton of useful epidemiologic data. So schizophrenia is an example of a DSM diagnosis that gives me a ton of new information if it was correctly made. That's not true. The problem with depression is it actually won't give you the same fidelity of information as schizophrenia in terms of common issues, common cognitive and emotional problems to work on. That are clearly interfering. So, but I want to. The reason I put this slide up is what I like about the DBT program and why I wanted to sell them a bit. It's not just that they're quote unquote doing good DBT. Right, that's part of it. And of course, this is a population that is not well served by the community, and it's important to have a team-based, you know, academic approach. But they're explicitly scientific in the way that I feel like I was not taught formulation, and that is that they are clearly, explicitly stating their hypotheses. They're explicitly stating what they're not going to work on. That's a little bit different than I think the more typical overconfident clinician that I fall into sometimes, which is like, I've seen this before, I kind of know what's going on. They tell me they want this, but I think they really want this, right? And I don't, and I think, and the problem is some of the time I'm actually probably right. I actually, but it's a real.
He gets intermittently reinforced.
I do, which is the worst kind,
yeah.
Right? It's the worst kind of reinforcement. And so that's what I really feel like sometimes that gets lost when we're theory forward, is we forget that the theory is only useful in so much as it gives us some testable hypotheses to start from. And this case is just a great example of the problem list. Because of what we know from borderline personality disorder, the problem list is an expected problem list, and the techniques address those specific problems that are clearly interfering with her. But the scientific approach should be the same regardless, right?
But when you do have multiple theories,
So what I personally would do is I would tell you this is my best guess. This is why this is my theoretical model. Here's why. Here's why I find it's the most useful model for this case. Here's the hypothesis this model gives me. Here's how I'm going to test it. And if it turns out that the test doesn't fulfill my expectations, then I'm going to either update the theory or I'm going to choose a different theory, right? And remember, you can do this. You don't have to. This is a process that isn't only choosing between the sort of brand name theories, right? This is a process that, remember, use the scientific definition of theory, and that's a well-supported grouping of hypotheses that tend to point us in a particular direction enough of the time that we can make a good bet, to use Paul Meehl's assumption, right? But we need to be clear about that. Sometimes people will say something's a theory, and they mean it's actually a hypothesis they have. And so a theory should be something that there's a body of data to support a particular set of hypotheses. And so that's where we sometimes we're messy with the word theory. I think that was you were first.
I'll be interested to hear when, in your formulation, the use of drugs in the overall treatment plan, when would you decide to use drugs or not to use drugs, and how do you arrive at what drug to use?
Medication treatment. Is that the question?
Yeah. Yeah.
Yeah. So this was so this case, because I stopped at the assessment standpoint, I didn't move forward, so that wasn't a part of what we discussed as my hypotheses. I wanted to do it as if I was just meeting this person. Right? I'm not going to change their Wellbutrin on day one, right? Based upon, unless there's some kind of risk. I mean, just to, so I would be thinking in the same way that I would about any other intervention, and I would say, what are the problems that this person wants to address? What do I see as getting in the way of those things? And I just want to make a statement. So I treat a lot of schizophrenia. I think treating schizophrenia is not a reason for using a medication, right? A reason for using a medication is to reduce something that's getting in the way of a goal. Right? And so I would use the same argument here. And so I just my hypothesis train would start something like this. It would say that she's reporting residual depressive symptoms. Antidepressants are low-risk medications. So there's no reason to stop it, but there's a reason to explore adherence and whether the trial has been long enough. So that I would start there, right? Yeah, but I would also say, I mean, this is where I think, make smart bets. Borderline personality disorder, I'm already thinking about, are the risks and benefits of a medication approach indicated for the level of affect dysregulation and distorted thinking? Right? Because we know that borderline personality disorder is likely going to have periods of highly distorted thinking and periods of severe affect dysregulation. Is the risk-benefit of the and that's the question I would ask. I think we talked about this a little bit. We often forget there's a risk of benefit to therapy too. We haven't just assumed that it's always going to be helpful, which should be part of our hypothesis generation, is that is this person getting better or worse? I dislike the idea that people need to get worse before they get better. I'm not sure there's evidence for that.
Yeah.
I have two questions. One is, how in a case conference what strategies do you use to contain countertransference so it doesn't become a cement session? It's very challenging clients. And then also, how do you avoid constantly moving back into the rabbit hole if the client keeps presenting with life-threatening behaviors, even when there's not indication for it?
Yeah, okay, so the first question was how to deal with countertransference in a case conference with challenging patients. I'll tell you how we do it in DBT, because we have a consultation team that's designed specifically to manage big emotions that come from working with people with big emotions. So one way is to be very descriptive and non-judgmental, and note it, and that means that if I'm really angry at this patient this week, which I get because she doesn't reinforce me because she has a flat facial expression, and I say, I think she hates me, she's driving me crazy, why is she like this? Then, my colleague Sabrina, who's sitting in the front, will ring the bell and say, can you be a little bit more descriptive? And will have me describe the behavior that I'm seeing and describe the effect that it's having on me and help me reorient to how I manage that. And so I think that being non-judgmental and calling each other on your stuff is the answer to that across places, I think, of being able to gently note that. But I think that cultures vary a lot on treatment teams about how able you are to do that. And I do think it's a challenging thing. And so if there's a particular treatment team that you're thinking about, saying, hey, this is something that might be useful for us to do, and can we practice? But you have to kind of actively, especially if you want people to say, like, like my thing that I love the most as a director of the program is if one of my staff tells me I was doing bad DBT, then I'll go buy them a latte, because I really want to reinforce that behavior, because that's a hard thing to do. So in terms of, can you repeat your second question about inpatient?
How do you avoid falling down to a rabbit hole and getting distracted by these big behavioral bursts when the client just continues life-threatening behavior even when they're in the supposedly most stabilized environment?
Yeah, I love your use of supposedly, right? So we don't have any data that inpatient helps people be less suicidal. I deal outpatient, and I'm trying to get my kids and my young adults out as quickly as possible. But I think, the idea of having your map is what helps you stay focused and not go down kind of misdirective areas especially when there's life-threatening behavior, because then your goal is really clear, right? It's at the top of that pyramid. Like, this is the thing that I'm working on, and I'm going to be figuring out not why they're doing this more broadly in a general sense, but why they did it today. right? What's the behavior chain that led to it today, and what's a thing that we can switch in that chain to make sure that the particular combination of factors, of events, of emotions, of actions that happen today doesn't happen again. And in some ways, you're kind of chasing a moving target, right? But over time, you know, the reasons that a given client cuts themselves tend to, you know, form one unified chain of like, oh, it's social rejection for this person, or it's whatever it is. And so you see that over time, and then you can target your interventions and the skills practice and the skills use and the different strategies around that particular reason for that person. But I think there is a temptation, you didn't quite say this, but I think this is partly what you're getting at. There's a temptation when there's a repeated behavior to really want to step back to the macro and say, but like, why are they like this? And this is something that we reorient parents to a lot. There's a parent that I'm coaching right now in our program that calls me a lot with like, her son did this today, but I don't know why it happened today. And I'm like, we'll get to the bottom of it. We can't answer that question. We don't have the data. And I don't want to make an assumption, because then I'm going to go forward with a plan to help that probably won't be helpful because it doesn't match what's actually happening. Yeah?
I noticed earlier that you said you made the grief a lower priority than the behavioral stuff. Mm-hmm. I understand why the behavioral stuff is high priority. Mm-hmm. But I was curious, do you ever make grieving a skill?
Absolutely. So the question was, would I ever make grieving a skill? Absolutely. And it's something we're actually doing it right now on a small scale. So I would frame it in behavioral terms. I would frame it as exposure, right? So it's exposure to strong emotion, and she's generally fairly emotion avoidant. So that is something that we're working on. Part of the reason it's a low priority is just because she was in so many treatment facilities that she actually has done a bunch of it. And so we do... It's low priority for her as well, yeah, and so that's where it is. But I could see with another client with a different story where it's going to be much more central, depending on if it's getting in the way of other things, yeah. All right. Well, thank you, everybody. Have a great Tuesday.